cases?
Yes, sir.
So this is the so you can see I have added here posters for wound debridement. Okay, earlier it was not there.
Yes, yes.
And again, always analyze the case. This is a long-standing diabetes mellitus with possible organ dysfunction, especially diabetic autonomic neuropathy. Septic wound in the leg with possible sepsis or DKA. If it is sepsis, adequate antibiotic control is very, very important. Then go to the history and examination to rule out involvement of cardiovascular system like silent myocardial ischemia, cardiomyopathy, coronary artery disease. All these things should be ruled out. RS, they can have silent tuberculous infection or pleural effusion. CNS, they can have earlier stroke or other cognitive dysfunction. Diabetic autonomic neuropathy, renal involvement, musculoskeletal in the form of, as you said, the prayer sign and other things for the last thing. And diabetic management by patient himself, whether he has been regularly taking the drug and going for periodic checkup, and any other insulin dosage and what are the drugs that he is taking. And in the examination, you must make a general thorough examination of the patient. And coming to the wound examination, they may sometimes ask you about the surgical classification. There is a classification called Wagner's classification, where depending upon the various structures that are involved, like skin and subcutaneous tissue, then tendon, then joints, like that, there are gradings for Wagner's classification, and looks for signs of septicemia and DKA. This is very, very important. You should never miss all these things. If the DKA is very severe, patient may have tachypnea, dehydration, hemodynamic instability, that fruity odor smell, all these things may be there. In pre of investigation, you must do the routine plus ketones, culture and sensitivity of the wound, as well as blood if you suspect septicemia. You must check for glycemic control. Electrolytes are to be tested. Then pre-op risk stratification based on the diabetic target organ dysfunction, sepsis or presence of DKA, and pre-op optimization by glycemic control, hydration, and antibiotic for infection. And intraoperative management, SAB is preferred but contraindicated in hemodynamic instability, coagulopathy, or severe sepsis or autonomic neuropathy. And the questions may be asked on femoral sciatic, popliteal nerve block, and ankle block. In an infected case, ankle block is contraindicated. Please remember that. Don't mention ankle block as a choice of anesthesia at all. You can safely mention femoral sciatic, popliteal, and nowadays we have other blocks like lower paravertebral blocks, 3-in-1 blocks. All these things are there. So this is the standard answer that is expected out of you. So please remember that. Okay, right. Any questions on that? Any doubts?
Any doubts from students?
Okay, so let us move on to Sang. If he has, what is his case? He has got to